Hello, everybody, and thank you for joining this webcast today. My name is Partha. I'm a consultant diabetes based in Portsmouth and work as one of the National Specialty Advisors for NHS England in diabetes. And today's talk is about the impact of COVID-19 for those living with diabetes, impact on the system, and how we have tried to look at the data and try and shape services accordingly.
So to take things forward, without going too much into details, it was first identified the virus in Wuhan, China. It's an enveloped RNA virus, also known as SARS-CoV-2. It's the seventh coronavirus known to infect humans. And as you can see, as probably would know, it causes the disease COVID-19, otherwise known as coronavirus, in 2019. So that's where we are with a little bit of background of the particular issue that we're dealing with. And as more studies tended to emerge, or the first findings came out from across China, as is now very well known, so many months down the line, fever, cough, myalgia were the predominant symptoms, and over the course of time, loss of smell and taste have been added in as well as identified symptoms. Fatality ratio at that point of time showed from China the strong age gradient, which further was confirmed in the hotspots such as Italy, Spain, where simply put, age was the biggest predominant to worse outcomes in those across the board, with or without diabetes. And as you can see in these particular papers that started to come out, the comorbidities of COVID-19 infection came to the fore. The meta-analysis of 8 studies showed the prevalent comorbidity, and diabetes was in there, as was other. In short, having another long-term condition or comorbidity most certainly predisposed you to worse outcomes if you had COVID. So this was the past. As things progressed, underlying disease, again, further papers come out, and again, a consistent theme across the board from all the different studies is the relevance of the underlying disease and what percentage diabetes affected. And diabetes obviously do bear in mind that none of these studies at this point of time spoke about type of diabetes, and diabetes being an overarching term as being a associated comorbidity and associated worsening outcomes in people who develop COVID-19. Why the associations of theory started to come out, and people with diabetes mellitus at that point of time was thought to have an increased risk of infection because of innate immunity defects. It was linked to hyperglycemia, both the acute and chronic effects, and very much went hand in hand with the big idea that we do need to keep diabetes control under check, and we do that in any infective process. So it wasn't surprising that this was an increased risk factor. What we also saw that age and obesity were possible main drivers. This was the data coming out from areas, as mentioned, from China, Italy, Spain, where age and obesity were possible main drivers, but though not much data was available on the type of diabetes. At that stage, when the initial wave came along in March, mid to end of March, the idea was to prioritize services. Very clearly, it was felt that outpatient clinics needs to go more towards virtual setting as much as feasible, but 2 types of clinics were prioritized to be left running. One was foot care and the other one pregnancy care. Pregnancy care for obvious reasons because of the impact on the child, or antenatal diabetes services ran, and foot care because of the impact it might have in the longer run without having these multidisciplinary foot clinic running. One of the decisions also made at that point of time was the prioritization of inpatient diabetes services. The idea being that we would expect lots of people with diabetes to come in. So we needed to ensure that diabetes teams were there around the hospital to guide and help ITU physicians, acute physicians, general physicians with their diabetes management, as their main care for COVID-19 was also being undertaken. Virtual support, as mentioned, was an important part, and the overarching system had advice, and there was clear guidance for acute and community teams. Community teams were asked to support people as much as feasible over this particular course of time, while mostly by virtual means, while nurse specialists were also asked to possibly join the acute teams to help out in the effort with the acute diabetes side of things, whether they were inpatient or indeed in general wards. These were the initial findings that we had from London, and we had a team whose remit was to try and collect data as it come along. So this was not these were not any trials, but these were feedback from our colleagues in London, which was hit the hardest, followed up by the Midlands, whereby similar data sets also came through. What we saw, as you can see in this particular piece, and most grateful to colleagues from Barts and Guy's, etc., St. Thomas's, who fed these information back. Atypical ketosis seen in type 2 diabetes. Also undiagnosed type 2 diabetes was coming in. So DKA mostly associated with type 1 in normal times. What we saw was more ketosis at this point of time. Fluid replacement was an issue, tempering due to management of DKA due to the risk of ARDS. Subset of ventilated cohorts, huge amounts of insulin were required, and this was a big issue that was picked up, and that had bearing on their discharges as well. As point 5 says, as they were being discharged on insulin, they needed quite a fair bit of support and help looking after they'd gone home, as the requirements will consistently then come down. So it needed guidance around those points of time. And also a little bit about the nursing, which was done in a prone position, and thereby issues with feeding, etc., thereby risks of hypos. So lots of issues, but these were very, very important and relevant feedback, which helped other teams across the country. This was the first piece of advice, as we had a group of professionals from across the country voluntarily giving their time up, led by Professor Jerry Raymond from Ipswich. And this was about setting up very simple guidelines on what to do when patients came into the front door with potential COVID. As you can see, patient assessment being at the top. But a very important point was to ensure all newly admitted patients were evaluated for diabetes, because as mentioned previously, we were having previously undiagnosed diabetes coming in. Glucose measurement, ketones, and we asked the stopping of certain products such as SGLT2 inhibitors at this point of time because of the acuteness of it. And I think it was important at this point of time to do it. Consequently, it has to be said that SGLT2 inhibitors, there is no indication to stop them as they are in the community, but this is more about people coming in dehydrated, and it's a overview as what medication we should stop when people come in a dehydrated state, and they extend not just to SGLT2 inhibitors, but other products such as ACE inhibitors, ARBs, non-steroidals, metformin, the whole cohort of medications a person with type 2 diabetes may be on. These guidance are on the Diabetes UK website for perusal by anybody, and the idea is this could be used by any department in the country. So there has been a follow-up of these. There's not only guidance for people when they're admitted, there's guidance for how to look after them when they are inpatient, including guidance on insulin sliding scales, what to do in case you don't have the infusion sets, because they may be used more in ITU for other interventions, so subcutaneous regimes. And also of importance is a particular guideline as to what to do when they're discharged from hospital. So an extremely good piece of work or set of work, which goes through the whole gamut of people coming in with diabetes during their stay and then discharged home. So a very clear process for all hospitals and teams to follow for people with diabetes admitted with COVID. On top of that, as mentioned previously, the strong indication from NHS England to ensure that hospitals had their inpatient diabetes teams running and not be disbanded during these times. The first paper that came out was the Open Safely Collaborative, led by Ben Goldacre and his team. And as you can see, this particular, without going too much into the details, the references are there in the slide, but this was a study which was very important, because if you look at the dotted line, what you're trying to see is how far away from the dotted line some of the what looks like TIE fighters, to be honest, are and where they sit. One big thing from the top, you can see the lower risk in people below the age of 40, and the really high risk as the age ramps up, and all the other issues there about the differentiation of ethnicity, deprivation being a big thing. In short, the more poor you are, the worse your outcomes. And I would like you to focus on diabetes there. There was no differentiation of diabetes, but simply diabetes or no diabetes. And again, there were two markers used, which was good control, defined as HbA1c less than 7.5%, and the others being more than 7.5%. In simple, plain terms, what this data set, the first data set to come out, showed that if you have diabetes, you have got higher risk of worse outcomes. If you've got an HbA1c more than 7.5%, you also have higher risk of worse outcomes. That was the first big UK-based paper that came out confirming the relevance of diabetes being an independent risk factor, as well as the importance of good control or not. The second thing that came out after that was the paper done by NHS England, where they looked at, as mentioned in this paper, all the deaths that have happened between 1st of March, 11th of May. This paper has been further extended, but it hasn't changed much the outcomes. As you can see, age being a huge determinant, and frankly, that is the biggest determinant beyond anything. The next ones, obviously, you can see the ethnic distribution as well as the socioeconomic distribution. But I would like you to focus on the diabetes types. Type 1 diabetes carrying higher risk than type 2. But important point there is the sheer number wise, type 1 diabetes obviously had much lower numbers than type 2 diabetes. An important point also to bear in mind at this point of time is that even though type 1 diabetes is naturally associated with a younger population, the average age of death in the type 1 diabetes cohort was 72. So very high compared to what would be the normal expectation in somebody with type 1 diabetes. I think it's worthwhile also mentioning that due to better care or whatever be the case, modern science, about nearly 50% of people with type 1 diabetes in this country are now above the age of 50. So age being the biggest predominant factor as far as worse outcomes do sit. And I think it was important to get that message across, because simply, understandably, there was a lot of parents with children with type 1 diabetes and a worry about school, etc., risk, etc. And it was a very clear message that there was no recorded deaths with type 1 diabetes below the age of 20 or 25. So the overall message, as has been consistently throughout, age, higher your age, worse your risk, as things stand. This is from the same paper. As you can see, the increased risk, which goes up, and the red arrow, which is the type 1 diabetes, as you can see, starts from age 59 upwards. So very low risk below that. And the other risk factors, again, you can see starts off from 39 upwards. So there is low risk to begin with at lower age groups, but still higher than the population who will not have diabetes. This was another piece of work which tried to answer the simple question, and this was not about the deaths during the period of COVID. This was just to say what happens during the period of time when we have had COVID. Has the overall death rate of people with diabetes gone up? Chart on top, type 1 diabetes, chart below, type 2 diabetes. This is data from 2017 onwards, and you can see some ups and downs and then a huge spike from April 20 onwards. So without putting too fine a point on it, yes, indeed, there was a big increase in death rates for people with diabetes during this period of time. So some salient points to also mention from these studies: people living with diabetes facing a significantly higher risk of dying with COVID-19. However, the strongest risk factor being age, and that is important to bear in mind. Helping assuring parents with young children, the absolute risk of death remains very low under the age of 40, with no recorded death in the data set analyzed below the age of 20. Higher blood glucose levels, obesity linked to higher risk. Too tight control also, and to a low BMI associated with increased risk. I would probably interpret that in the light of the fact this could be related to frailty, could be related to background cancer. We don't know the details of it, but that's the data as it stands. I mentioned about the overall death rate increasing, and ethnicity and deprived communities being at a higher risk. An important point also to mention that if you have type 1 and type 2 diabetes, those with pre-existing kidney disease, heart failure, and previous stroke were also at higher risk. One paper to read, which I do ask everybody to look at, if you want to spend some time, this fantastic paper done, authored under the stewardship of Stefano Del Prato, which has come out recently. And this looks at all the studies that have been done. I mentioned a few things, but this is a really good summary of all the studies done so far, looking at background of diabetes, emphasizing the importance of diabetes being a risk factor and the importance of good control as well. Again, this particular paper also looks at a breakdown of the HbA1c, and I think if I can summarize that, an HbA1c more than 10%, according to all the studies, carries quite a significantly higher risk. Definitely goes up from 58 onwards. If you're above 10% or 86 millimoles per mole, it certainly is a high risk. Potential mechanisms being discussed. Again, as I said, an excellent paper to look at and go through. It talks about the potential mechanism, lots of theorizing as to why people with diabetes have got worse outcomes. So as you can see, the theory being the beta cell damage, the cytokine storm, all of it leading to the admission hyperglycemia, worsening control, and also probably as to why you have new onset type 2 diabetes coming through. All of those reasons, the obesity, inflammation, coagulation factoring in and thereby causing extremely poor outcomes. So important to have an idea. These are theories, I must stress, but at the same time, an excellent paper, an overview, which does give a possibility as to why people with diabetes do indeed have worse outcomes. What has been the response to the data on a national level? We set up a national advice helpline along with Diabetes UK and industry partners. And the idea was, if you can't get in touch with your local centre, as they may have been busy in the COVID-19 work, here was another line to help you in case your blood sugars were under control. So Diabetes UK were fantastic in helping us with the person-to-person contact, person with diabetes. But when they needed some clinical input, this helpline was there to help people as well. There's a self-management and education platform with type 1 diabetes for every single person with type 1 diabetes that's been launched for free across the country. So in these virtual times, how do you help people while they're at home? If you're age group 0 to 18, the established platform is DigiBeat. And if you are anybody above the age of 18, then the established platform is My Way, My Health Diabetes. So I would suggest you please have a look. All the details are on the NHS England Diabetes platform website, and it gives you free access. If you do have type 1 diabetes or you look after anybody with type 1 diabetes, please do direct it to them. It will be much helpful of benefit while they're at home, worried. Any self-management tips could be useful as we try and focus on the modifiable factors, which I'll talk about in a minute. There is also a similar platform for type 2 diabetes on its way, and hopefully, fingers crossed, we can get it out on time so we can try and see what we can do to help things as we go along. What are the further things? Further discussion with Chief Medical Officer regarding shielding categories, and that ties in the risk calculator I put in there. Hopefully, we'll be expecting something coming out from the Oxford team, which will be a risk calculator for people across the population, and hopefully that will help in determining which patient groups need to be in further shielding. We have been asked this question many times: should everybody with diabetes be shielded? The answer to that, based on the data, is no. Because if you look at the risk for somebody who is, let's say, 7 years old with type 1 diabetes, is very different, as it is different for somebody who's 52 with extremely good control, but from a white background, compared to somebody who may be 62 with an HbA1c of, let's say, 74, but from an ethnic background. So very different risk factor, which is why the risk calculator would be quite useful. I mentioned dexamethasone, which is going to be quite important because it is obviously now a established and proven treatment for people who are very poorly or needing oxygen or on ventilation. And the dose suggested as per the trials is not insignificant per se. It's nearly 6 milligrams of dexamethasone or close to 40 milligrams of prednisolone. I have previously mentioned about the website of Diabetes UK and the team brought together by Jerry Raymond, which has done lots of guidelines. One of the more recent guidelines has been about dexamethasone in people with diabetes. Please do have a look at it. If you have to use it in a hospital setting, it's very clear guidance to the teams as to what regimes they should be on to try and help them with dexamethasone, so to speak. Vaccine, I put it down there because it is going to be a hot topic. And again, we would expect that this would be available for anybody who is eligible for the flu vaccine as it stands. And as you might know, anybody with diabetes has priority for the flu vaccine as well. So hopefully this will be the case, but conversations are ongoing. I mentioned about occupational health. There is an extremely good website called ALAMA, A-L-A-M-A, and we have worked with them to try and guide people who work about the risk factors and see whether that's of help. So please do have a look, because they talk about a concept of COVID age, which is an interesting concept, but gives an idea as to where things stand and how you can have that interaction with your occupational health department if you have a background diabetes as to whether you should be at work or not. And finally, it's a question of reassuring everyone with diabetes. And I think I'll take a pause and say, what should we say to people? And my personal advice is to anybody with diabetes, the message is the message. There is no sugarcoating or putting it in a very nice way that if you have diabetes, you have got higher risk. That is the science. However, what we need to focus on is the factors we can try and modify. There are non-modifiable factors such as your age and your ethnicity. You can't change that, so there's no point in worrying about that. There are some factors which are probably partly modifiable, but beyond the control of the individual, such as socioeconomic deprivation. But there are 2 or 3 things which we can try and focus on. So we talk about the weight being an issue. We talk about the glucose control being an issue. I absolutely and fully appreciate it's easier said than done, especially for people who might also have a life of privilege, like myself, that you should, have healthy foods and exercise regularly. But at the same time, we should try and support people as much as possible to focus on those 2 modifiable factors. We use all media outlets to provide a consistent message of reassurance and hope. This will pass, but at the same time, we need to protect people as much as we can. And we are continually looking at the data to pick any obvious other triggers. We're looking at medications as to whether there's anything which makes things worse. So far, we haven't picked any, which is extremely reassuring. We're looking at amputation rates, which again doesn't look like it's gone up, which could be a testament to the work done by podiatry colleagues all across the country, primary care colleagues, as well as the benefit of keeping food services open. And I think it's important we also prepare for the future of what we do to play catch up. How do we prioritize lists? And on that point, the prioritization is and should be an important point. There's some extremely good guidance which has come out from Primary Care Diabetes Society and ABCD, which you might want to look at. And there is some work going on in NHS London as well, which should help guide as to which patient group should be prioritized ahead of others as regards trying to protect them. That doesn't mean anybody else should be ignored, but I think it's important to have that discussion as to who has to be prioritized ahead of others because of the risk of COVID-19 in these times. I mentioned about the Primary Care Diabetes Society guideline. Here is some which you might find of benefit. Here is an example of where to face urgent face-to-face virtual and where you can defer appointments and give them something else instead, some virtual platforms, etc. A particular paper to mention, and this might be something of use. It has my name on it, but it's got some fantastic authors on this one who have tried and looking at remodeling diabetes service and emerging innovation. If you feel it's of benefit, please have a look and give some ideas and views as to what we could be doing in these present times about reshaping diabetes services. And finally, lessons, acceleration of much needed care, much needed issues such as digital innovation, but it's got to be care with access. Socioeconomic determinants continue to be an important thing, and we need to ensure we have the cultural sensitivity around it. And an important thing is while we're giving access to technology, we do not widen that gap, because that's going to be very important that we keep that gap close, as COVID-19 has shown very clearly the relevance of the socioeconomic determinants.
Thank you very much to everybody for listening to that talk. Hopefully it was of use and gives us some idea as to how to look at people living with diabetes, how to look at services, gave an overview of the data around it and some of the possible signs which might be causing the issues that we have at hand. Hopefully that was of use, and we hope to meet again in future times. Thank you.